Good afternoon. I'm Matthew Holt. It is the 9th of December, 2021, getting towards Christmas time at the end of the year. I am the founder and publisher of the healthcare blog. This is THCB Gang, and we have a fine lineup, and they include two guests today. So let's dive in quick to who they are. Kim Bellard, regular contributor and writer on THCB. Ian Morrison, my old boss, healthcare futurist. Jen Benz from Benz, expert on employer benefits. And our two guests today are Kumar, who hasn't been on before, but has been on a couple of my other shows, from GSR Ventures in Menlo Park, California, which is where Ian lives, and Bill Taranto from Merck's investment fund. So that's who we got. I will try not to screw up any more, although that may well happen during the rest of the session. So let's take it away. We are live and everyone's here, and I want to find out what everyone has been up to and looking at the last few weeks. So I'm going to start with you, Kim.
Well, a new report just came out and said the world is not going to be ready for the next pandemic. And I'm like, gosh, we're not ready for the pandemic that we're in. Ron Johnson thinks that gargling with Listerine can combat COVID, and the Senate just voted to strike down Biden's mandates, and the Omicron is rising like crazy. So I don't think we're going to make it to the next pandemic.
You think we're going to make it to the end of 2021?
I don't know. Get this year over with.
All right, Jen, what have you been up to? What are you looking at?
Similarly, I've been keeping an eye on the vaccine mandate and all of that's going on with that, with the Senate countering it in a symbolic gesture. But what's interesting too is the Kaiser Family Foundation put out new data about how many workers are actually quitting because they don't want to get vaccinated. And they are saying that it's only 5% of unvaccinated workers, or 1% of workers overall, saying they left their job because of the vaccine mandate. But I'm guessing that that's going to start to increase. So that's going to be something interesting to watch. And retailers were already saying we're not going to enforce the vaccine mandate because we need people to actually work in the stores for the holiday season. So that's kind of what I've been keeping my eye on the last few days.
All right. Ian, what have you been paying attention to?
Well, I had kind of a week of from the sublime to the ridiculous. Spent Tuesday attending and speaking at PBGH's quarterly meeting with all the employers. So I'm glad Jen's on and we can maybe compare notes on that. My takeaway from that is, on the one hand, they're going to become more activist. On the other hand, they're becoming more generous because of the workforce shortage. So it's really an interesting juxtaposition. And then yesterday we had our Martin Luther King board retreat that I facilitated. And I'm on the board jointly with the foundation board, and our good friend Andy Slavic came by and we kibitzed a bit with him. But the interesting thing there is, we're a system that is 97% non-commercial. Okay, it's poor people and all Medicaid. So going from employers who are adding benefits like crazy to safety net institution was kind of an interesting juxtaposition. Common thread, I think, is worker shortage and worker issues. So we maybe get into some of that with Jen's expertise.
That's interesting. Sunny, I'm sure there's a massive worker shortage amongst VCs and having to recruit.
You joke, but in our industry, the digital health field has just seen such massive growth, and it's going to be a sprint to the finish line. I think both the sector and even within our fund, we've seen such huge growth across the entire field. I think there's no question this will be by far the biggest year for this entire digital health field. It's fantastic that we've been able to see such activity, but it also creates a lot of challenges with it. And I'm sure we'll dive into some of that during our hour here together.
Yeah, I'm sure those of you who noticed the $300 million that went into Cerebral yesterday for for a company which didn't exist. What?
That's right.
It's now already raised $400 million.
That's right.
Financing more meds than anybody else in the mental health field put together. So some interesting changes going there. Bill, I know you have some forecasting stuff that you've written up, but we'll touch on that in a second. But what have you been looking at in the last few weeks?
We can get to that. Actually, two things. One, as it relates to the vaccine, I have a 17-year-old and a 16-year-old daughter, and Pfizer just approved the booster for them, so I'm pretty psyched about that. So I'm going to get them quickly to get their booster tomorrow. But and then this year, so Sonny was saying, this year won't end. We did 10 new deals and 7 follow-ons, and I got 2 closes we did this week already. I got 2 more. I can't get this year over. I just want to stop and have a break. The year will not end. And Sonny can attest to that. It's just It's crazy in digital health right now. I can't keep up.
I like it. We're going to rename the show The Whining Venture Capitalists. Right. You're probably having to work those 60-hour or 70-hour work weeks. There's probably going to be a Fortune article written about what tyrannical bosses you guys are any minute. Well, I cannot let the week go without the best story of the week, which is that the University of Miami has gone and got is getting a new football coach. Who is the current football coach at the University of Oregon. I must know I don't follow college football a lot, but I thought it was great that they had to both pay off the current coach who they're firing for being no good, costing them about 10 million in payoffs, hire the new guy at 7-8 million a year, and then pay Oregon some compensation for taking him early, which all total up to about 50 million. This is reported in The Athletic, which doesn't often get a mention here as a healthcare paper, but they had a great line where said the reason that the university could afford it this year is that instead of last year where they lost money, or because of the COVID recession, they made about $400 million profit more than they expected this year in their hospital and healthcare business. And that's how they're going to afford it. I also noticed that the amount they got in CARES Act money was about 50 million, which is about exactly the same as the amount that cost them to change his football coach. So the good news is that we found something as corrupt and devious as American healthcare, and it's American college football.
Well done.
All right. Well, let's dive into the first thing, because this is impacting everybody, and I wanted Ian and Jen to weigh in, but I sit in those places where I see all the appeals from the companies that Bill and Sonny are investing in, saying we're desperately looking for these 25 different types of employees. So where do you think we are on the employment front? I hear that many hockey leagues and recreational soccer leagues are cancelling because they can't get enough referees because people aren't coming back from the pandemic for that. So, but Jen, where do you think we are overall? And I'd love you to weigh in on what the PBH folks are saying.
Mm-hmm. I mean, I think depending on where you look, people are really struggling to get staff, where they're seeing people leave in different patterns than they have before. I think that's all over the place at both the highest ends of the workforce and the hourly workers who we know have really kind of had enough with the treatment they were getting pre-pandemic and during the pandemic. I did see, though, some interesting data today that questioned whether or not the Great Resignation really is as big of a shift, or if it's just the continuation of this trend that has been happening for the last many, many years. So I think that's going to be interesting, but just to kind of see how that folds out over the next couple of years. But for the people who are losing folks and who can't keep their stores open or have to close their restaurants a few days a week because they can't staff them, it's very much a real thing right now.
How much do you think this is about pay? I'm seeing ads. I mean, I live in Tony Marin County. I'm seeing the local supermarkets trying to recruit people at $20 an hour plus benefits, which sound 40 grand plus overtime to work in a supermarket doesn't sound terrible, but then you figure out how much does it cost to rent an apartment around here, and then you go, okay, it's not that great. How much do you think is around pay versus that we're going to have to figure out very different ways to do things? And then perhaps Ian, you can come in on what PBH was saying regarding the health benefits side of this.
I think pay is a huge piece of it, because a huge portion of American workers just don't make enough money to live day to day, even though they're working full time. And we have to be able to address that as a country. And then I also just think that the way that work works is so outdated for so many people. And, a great example of this is for hourly workers. The city of San Francisco passed really revolutionary legislation several years ago that required employers to give people a week's notice of their schedule. That's pretty baseline. So we can't even get people their schedule more than a week in advance if they're working hourly. And then we wonder why there are these big disconnects. So I just think there's so much about how work happens that hasn't caught up to the way people's real lives are. And that combined with the pay inequity is a huge, huge issue for us to solve.
Yeah, I also think you still read a lot of statistics that it's still also, whether it's your direct boss, but it's management that people, which combines with the work environment. People are not satisfied with the work environment. Then when you combo that with the pay and or lack of opportunity, or the different things, and you see why people are not staying within their jobs, and it's across every industry. I mean, we see it in healthcare, all the way from the corporates all the way down to our digital health companies as well. Staffing has not been easy, and then I agree with your point, Jen, that people don't want to go into an office anymore. They want to work where they can work, and you have to allow that to happen. There's no reason to have brick and mortar anymore. We figured that out in the last 18 months.
Yeah.
Well, there is for a lot of jobs. And, I suspect that the people who are most leaving their jobs are not the people that were able to work remote before. It's the people in shitty jobs, honestly.
Right. Agree.
Yeah, I think that's the key point. I mean, work is kind of overrated, right? And if you don't have to do it, but I think Jen raised an interesting point about what is cyclical and what is structural. What's the long-term effects? Because I think a couple of things are going on. One is that because of at the higher end and at the older end of the workforce, because the market is up so much, people are looking at NASDAQ over 16,000 going, you know what? I mean, I can make it now. So I'm out of here. That's very different from the bottom end of the labor market, where you've got all those pressures. And I think, with the cushion that the CARES Act and other investments did on household finances, that's a shorter term effect. Eventually that money runs out and you've got to go back to work. But I mean, what I heard from the PBGH guys was the war for talent, as Jen said, is all up and down the spectrum. It's at the low end and it's retention at the high end. And so, I was out in a limb saying maybe the pandemic would be a turning point in health benefits. And I'm reversing that call. I mean, I think we're not going to see a big decline in people abandoning health benefits because of the necessity to attract workers, which compounds, if you look at healthcare financing models, every health system I work with is dependent on charging Apple or eBay or somebody 300% of Medicare to make the math work.
Yeah.
And that, it seems to me is only going to intensify, because if you look at the workers, the situation with health systems, revenues are back up, but costs are going up 2 percentage points faster than revenues are. So the margins are declining, and it's both labor and supply costs. And by the way, I mean, and I'd be curious of bringing in the digital health story. Despite the great year of digital health, everyone I'm talking to is back up over pre-pandemic levels in terms of in-person care, emergency room visits. So, it's going to be really interesting to see the next 12 months.
Absolutely. There was an interesting post by Jonathan Bush and one of his colleagues from Firefly, which is one of the digital health startups, complaining about some legislation that's now forcing people to go back to in-person care in advance of prescribing certain drugs, including, Ritalin and stuff, which I think half of America's population under 50 seems to be on anyway. So I think there's some controversy over that, but yeah, it doesn't look like. So Jeff Goldstein wrote an interesting article on THCB a couple of weeks back, looking at the overall, the fact that COVID was actually deflationary for healthcare compared to everything else. The healthcare spending stopped going up. A lot of that, of course, was volume rather than price, right?
Right.
And if we're now back on volume and prices are still taking up, and then either the work from the Healthcare Cost Institute or anything else shows you that, healthcare pricing all over the place, even though volume has been relatively steady over the years, the prices have continued to go up, and that's why spending's continued to go up. So it's hard to see. My conclusion is we did not come out of COVID with any structural change around healthcare at all. I don't know if apart from the working from home thing, I don't know if we came out with much structural change around work. And you could argue that this would be a time where, after a sort of big shock like that, we might have thought about doing, changing work hours or work weeks or what have you. And I would assume planning to bring in a lot more automation, which will happen for any jobs that can happen. But it seems to me we're still, it's as Kim, what did you say at the start here, Kim? We haven't figured out the pandemic we're in, let alone the next one, and all the secondary effects haven't really been figured out either. My last complaint, as we're all whining here, is that I actually went to see my doctor, who said things like, you're fat and you should go on a diet and we'll start working out, all the stuff he's supposed to say. And I live in Marin County, which I just saw today has the highest rate of 5 to 12-year-old vaccinations in America and probably in the world. We're all very proud of stuff. So I've been to the shopping mall to have my own jab and to have both my kids boosted. And then my doctor told me I had to have this thing called a Tdap, which is another vaccine. And I forgot how much that hurts. 2 days later, my arm is still hurting like hell from so I won't get to tetanus or pertussis hopefully in the future. But, medical care is still going on. As you said, there are some things you have to be in person for. But it is interesting how we're still in, and I was on a panel about health plans yesterday, trying to figure out who is in charge of this sort of managing the virtual to the physical, and who wants people to go back in person. And I mean, Ian, you said this many times on this show and elsewhere, that a lot of the reason to get people to come back in person is to find other stuff so that you can find the expensive stuff to refer people into the inpatient side and do those expensive procedures. And we've had changes. We've had the Surprise Billing Act and some other stuff, but it's still very much there's uncertainty about when to go to work. Jen, there's uncertainty about how much healthcare is going to cost you.
Mm-hmm. Yeah, but you know what? The interesting thing about your both comments is that the thing with the whole COVID and the telemedicine, it was all acute care, right? And what's happening is 85% of people that seek treatment is for chronic. Right. And so the question becomes is when does, which I actually think is one of the things that we might see next year is the movement from telemedicine from acute to chronic. Right. You saw a little bit with Livongo and a couple other companies like in cardio, but the question is the broader chronic market. And that's the issue, right? Because there's no telemedicine really in the chronic market just yet. And if somebody can tap that, then that would be very interesting. But that's the reason everybody's going back is, yeah, you can do acute care easy over the phone, but you can't necessarily do chronic over the phone. Or there's not enough infrastructure yet to do that.
I would even go maybe one step further. I would say it's just fundamentally an incentive problem. I mean, the incentives today are all structured around getting people in, as you mentioned just now, Matthew, getting those expensive procedures done. Those expensive procedures are still done in person. As long as those incentives are structured in that way, you're going to want to have people come in so that you can do those procedures. As long as that's, how everything's structured, that's what you're going to have people incentivized to do. And I think that's fundamentally still 95% of how the US healthcare system is structured. There are exceptions to that, to be clear, but that's still the very much minority of how healthcare is delivered. And that's the problem that we haven't yet been able to break out of. So there are companies out there, there are systems out there that are trying to change that, but there's still, even post-COVID, a very, very small minority of how healthcare is delivered. And I think we're trying to get that adopted in much, much greater volumes, but it's an uphill battle. And I think that's where we really need to focus our efforts.
So certainly, Bill, on that point, right? So we've had by now, I don't know, you must have seen, I've seen hundreds, so you must have seen dozens, if not hundreds of pictures of companies saying, we have the remote patient monitoring capability. We're going to get paid by Medicare to do this. There's, I have companies who are doing it for, we're managing people's chronic pain by them recording how much level of pain, and that counts as a remote patient monitoring. And we even had Anish Kokran here, the cardiologist, a couple of weeks back. He was on, and he was saying, actually, I'm doing some remote patient monitoring. I said, which firm are you using? He said, oh, my mate round the corner set up his own, cardiologist set up his own company. I'm using him. But he also said, interestingly, that, that works for some of his patients, but a lot of his patients, he feels that they need to be seen and he needs to see them. And and even that means them coming in quite a bit more. So, I think that there's some cultural balance. There are some patient groups who are going to be tricky, but the two of you, there's been so much money invested. Best Buy bought a company in this space. Yep. There's this pressures towards this remote patient monitoring. Are you seeing in the numbers you're seeing privately? Are you seeing this start to tick up enough to make it interesting?
I'm certainly seeing it. I think that's they all connect together, right? A lot of these themes. Telemedicine is one component, but I think you're starting to see remote monitoring of everything. they finally moved out of cardiovascular and diabetes, right? That's always the two main areas where you know, Holter monitoring, the old traditional cardiac monitoring of AFib and those type of things. But what we're starting to see is you can actually start to move into a lot of other areas of monitoring. And, you know, even if it's just basic stuff about the penalties of readmission for different, you know, chronic illnesses. There was some crazy number of $600 million in penalties for readmission last year. But I also think that's another growing area. You know, aside from going into chronic care or telemedicine, you've got to expand remote monitoring into more conditions beyond what we see today. And the reality is the devices are smaller, faster, better. They collect more data. There's more clinical validity around a lot of these monitoring devices. It's just, you know, where's the appropriate place? You know, obviously I'm with Merck, and, you know, we're obviously a big oncology company, but we don't see really remote monitoring yet in oncology. What would you monitor? Is it pain? Is it adverse events? You know, there are things you can monitor, but, you know, we haven't seen it there yet, but I can see the market for it if you know, somebody comes up with, you know, the right type of tool that's there.
But Bill, I want to push a bit on that, because I've seen a number of companies recently who either new or relatively new, and there've been a couple for around for a while, who are looking particularly at cancer, doing kind of navigation. That you guys invested in one, right? Navigating cancer, I think. But a number of others who are doing kind of AI-based, sort of replace the nurse calling the patient and doing a sort of continuous communication backwards and forwards. I don't know, Sonny, if you looked at these or got any money in one of these. I know you know a lot about AI. But, you know, there's some things where you can say, is it really remote monitoring? Is it a blood pressure cuff, or is it a diabetes, you know, blood glucose meter where you can see a number, versus, you know, there is that continuous high touch communication. A lot of the players, especially in these virtual primary care folks, are talking about, oh, we're touching our patients every, you know, 2 weeks or once a week or whatever. Or in the mental health space, there's, you know, we're texting back and forth between either a bot or some combination of a bot and a human, and we have coaches and we have, you know, people doing this stuff. I guess my question is, you know, can we say that what Medicare calls remote patient monitoring will pay a code for, versus sort of doing continuous care oversight or surveillance or management, or whatever you want to call it? Are they close enough? And yeah, you say you don't see a lot of that in cancer, but I mean, are we going to? Do we have the push that we're going to see so much more of this, just because there's so many of these companies about, and every one of them has got a sales guy calling every doctor, health plan, pharmacist in America? What do you think?
Yeah, I don't know if we're close enough yet. I mean, when you look at where monitoring works today in a closed loop system, there's still, I mean, the technology in Excel, like you look at, for example, one of the companies we had that we sold to Boston Scientific, Preventus, which monitored AFib. And could predict whether but in the end it was just monitoring. But the closed loop nature, it still had to go to the cardiologist, who then would notify the patient, right? And so there still has to be that interaction. Just, you know, the device just monitors something. It doesn't actually practice medicine. And so the question is, how do you get that closed loop system and fully integrated system to work for the right condition? And I think we're, you know, it's like I said, you see it in diabetes, you can see it in cardiology right now, but I think in a lot of the other therapeutic areas, we're not quite there yet. But, you know, I think it's a place to invest and try to build it out. I think it's the right place. I don't know Sonny things, but
yeah.
I don't follow
Sonny then Kim. Sorry, Sonny then Kim.
No problem. So this is very near and dear to my heart. I don't know, Matthew, if you know this, but I actually started a company in this space about 5 years ago. So we were a little too early, and truthfully, the company failed. But it's something that
we're trying to get Justin, your colleague, on the show. That's what the company succeeded doing the same thing, but yeah, we got you instead.
No, but honestly, like, you know, remote patient monitoring is something I'm incredibly bullish on. I do believe it is the future of how medicine will be practiced. The challenge, though, is how do you create value? And honestly, if you ask me, is, you know, tracking blood pressure, is tracking blood glucose enough? Honestly, the answer is no. That's what's, you know, being done today. There are codes, you know, 99453 in the, you know, CPT code that you, in theory, can get reimbursement from if you track it, you know, whatever, 16 days a month. Is that enough to generate real value? Is that enough to actually move the needle from a health, you know, society perspective? No, you're not really going to improve patient outcomes. You're not really going to improve patient lives. And that's my problem with where the RPM kind of system is today, we have to take that one step further. We have to show, okay, if you're tracking these metrics, how can you reduce the incidence of stroke? How can you reduce a patient's A1C? And how can you do that sustainably? How can you do that better? How can you do that at lower cost than our current methods? And at least so far, I haven't seen that done at scale and sustainably. And I think that's what's missing in the RPM ecosystem as a whole. Once we can do that, once we can show that you can use technology to do that at scale, at lower cost, at a better patient experience than what we can do today, then you'll have really unlocked the potential of RPM. And that's when this can become a true game-changing technology. And you should be able to do this with RPM. It just hasn't yet been unlocked, at least as far as I can tell.
Yeah, I would agree with Sunny. The problem is it's all episodic, right? Because we're monitoring chronic disease, but it's, to your point, Sunny, it's all episodic. Did their A1C spike? Okay, well, do your diet and exercise, whatever you have to do during that time, and maybe lower it. You're, again, in the cardiovascular monitoring, that's a 7-day or 14-day Holter monitor. It's episodic. Then you stop. The problem is with the chronic patient is it's continual, right? And we're not. I couldn't agree more. We're just not there yet. But I'm with Sunny though. I think it's the big future of where healthcare is going. I think there's going to be a lot of capital put into the monitoring space. It's just, can we get to a clinical validation for that chronic patient? That's
well, and it's also.
Sorry, can we go Kim then Ian, because Kim was trying to jump in.
Sorry.
So two of the issues that I'm not sure we really addressed is I think we're a lot better at remote monitoring than we are at actually doing something with the data real time.
Yeah.
And even so, we're not good at all about, well, what's the liability for whoever has got that data about how quickly they react. So you can monitor something and something bad happens. Do you know about it quickly enough, and do you act upon it quickly enough? Until we address those two things, remote monitoring is going to hit a wall.
So let me ask a question. I want to go to Ian and then Jen. I will, if you're not careful, I'll put on my chart of the continuous clinic, which I've been showing for 2 years now, about how we should have an organization that should be doing all this stuff.
Yeah.
But I mean, I don't quite. I mean, I thought at one point Tele Livongo was going to get there, and then I bought their stock, and now I'm just grumpy. but we'll get into that subject. We'll get into that subject by the end. I'm not letting these guys get off the line without talking about the stock market. But Ian, if you talk, I mean, you talk to employees, you talk to a lot of hospital systems. No, it's the old question, right? Who's going to receive the data if a patient sends you all their information? I was kind of kidding. I went to see my doctor at One Medical, and he actually had my weight that came in there, but it was up to 2016 because my Withings scale had been connected, but then somehow it broke. So like 4 years of missing weight data or whatever. But nonetheless, are you seeing enough change in the hospital systems you're talking to that are starting to figure out how to put in the procedures and process and people in place to do all this stuff, or is it still just being dumped on the primary care doctors?
Well, but it goes back to a couple of points that have been raised, right? One, Sunny's point about the alignment and on the value-based payment models to support it. And, I think we've gone backwards rather than forwards in the last 12 months on all of that. I'll give you a specific example. And Kim's point about there's got to be a there, right? Somebody who wants to receive it. Our friend Bob Wachter, makes the point that the worst nightmare of our primary care doc is getting Matthew's continuous readout on every bodily function. I mean, what a bloody nightmare that is. And what are you going to do with it, right? In Scotland, they just don't find out, and it doesn't make a blind bit of difference because most things are either going to get worse or better, and there's not much they're going to do about it anyway, either way. But anyway, that's my cynicism. But I'll give you an example of a conversation we were having with Slava over the last couple of weeks with regard to MLK. He's doing the city block thing. He's an investor, and he's sort of doing the pinch hit CEO thing. And that model is really interesting to me, but it works. It maybe works in Brooklyn. I don't think it works in LA because per capita spending Medicaid in Los Angeles is way lower. I mean, California has the lowest provider rates. And this is a conversation we were having yesterday with our board at MLK. You can manage care and you can do what you want in terms of these innovations. If the total pot of money is insufficient to deliver decent services, you have a problem, right? And the shortfall is pretty significant. I think in California, you'd have to double Medicaid rates to basically get a meaningful amount of deal flow in the system. And that's where I'm very concerned about, both in MA and in managed Medicaid, that pilots may work and some proof of concept may work. Are these scalable up to a point where they can actually be for everybody? And that, I think that's a big operational and execution challenge that the new digital players have in the next 12 months.
Well, there's another related point. I want to come to Jen on this, because the other thing is a lot of this innovation, you know, the folks you're funding, Sally and Bill, or could be funding, or your colleagues are funding, are heading out looking for, you know, value-based people, and they end up at employers, right? Because, and if it goes, then what do we just say? It works very well for people with diabetes and heart disease and strokes. Aren't many people in the, I mean, Jen, the people in the employed population care much about that? I know, you know, Livongo did pretty well, pretty quickly getting to people with, you know, diabetes. But if you think about those populations, they're mostly older and sicker than the typical employed population. Or am I wrong?
Well, I think we've talked about on the show before how there's a huge gap between what the, you know, folks who get their healthcare through the highest value employers versus everyone else, and kind of that big disconnect. But I do think there is a significant overlap if you look at most large employers' biggest healthcare spend areas. You know, a lot of there's been a ton of money and attention that's gone into diabetes prevention. Depending on what industry you're in, there's a lot of musculoskeletal, and then of course mental health, which we haven't really touched on how all of the remote and virtual care options fit with mental health, but that's a huge focus right now. And then cancer is very costly for employers, and high cost surgeries. So you have a lot of companies and a lot of attention that has gone in the last couple of years to getting people to the right points of care for the things that cost the most money. And so maybe it's not as large a portion of an employer population as the rest of the public, but those are still where the high costs are. And so you have the kind of care navigators like Accolade and Health Advocate that try to get people through the system in the best way, and a lot of attention going there. And then you have the direct contracting, you know, centers of excellence and second opinion providers and things like that. And all of that is kind of making its way into the market.
If you believe for a second, and I'll come back to you if you believe for a second that the new virtual care digital health companies, you know, who can, and by the way, the navigators are becoming those, right? The navigators are now adding primary care, and you saw Grand Rounds had Doctor on Demand, and they're apparently going to now call Included Health, and they're going to go public next year, actually, all this other stuff. If you believe that they can do that, they can sort of combine like transparent centers of excellence with Bill, are you guys in transparent as well? You have to be, because the last time around long ago.
I follow Glenn everywhere.
You have to follow Glenn Tillman everywhere. We started, Jessica and I started the rumor that she was conspiracy theorying about him. I said, oh, he must be Q. And she said, what, you think he's cute? I mean, no Q. Anyway, we ended up in a complexity about that. But I mean, if you think about what they're doing, right, which is basically attaching centers of excellence and diverting people, hoping to save money doing that. Yeah, I believe you can do all that. The next question is, can you move enough employees into those areas of, you know, into those systems? And I would put one thing here, which is that Dave Chase, who many of you know, has been running around the country for 10 years now, talking about his new healthcare Rosetta, which is basically a way of funneling employers to a limited network of low-cost providers and putting in primary care at the workplace to stop crazy stuff happening, right? Had amazing results with like five maybe 20 employers. Mm-hmm. He always quotes the Rosen Hotels, which has been doing this for 20 years. Doesn't seem to be able to get to any big employers and to move people in any system. I mean, why isn't, back to like, if it's so good, why hasn't everybody got one? You know, and I don't know, are you seeing any, and Ian said, tell us that, and you've been saying that employers are so desperate to get people, they're not going to mess with their benefits. So where do you think, I mean, employees around going to do that?
I'm eager to hear what Ian says, but I think this gets to one of the fundamental flaws in how we have designed the healthcare system, which is that we have made it seem like choice is a good thing. You want the network with the largest number of providers. You want the PPO plan where you can go anywhere. And everything has been about choice being a good thing. And now we have to completely reverse that and say, no, no, no. Why do you want to go to everyone? You want to go to the best doctors. And who's going to help you figure out who the best doctors are? Your employer, of course, because they're the ones who care the most and they're the ones who are unbiased and so forth. But that's a huge shift. And we're just starting to adjust things in the opposite direction.
Yeah,
Yeah, just imagine, look what a great job they do buying cubicles for you. Certainly they're good at doctors too.
Right.
They're also laying people off 900 at a time on a Zoom meeting. I should be laying all you guys off, you know.
Well, it goes back, Matthew, when I joined the Institute for the Future in 1985, I wrote a piece called Docs and More at the Company Store, because it was a trend back then too. And, I said, do you really want your psychiatrist to be your employer? But anyway, no, I was just going to say ditto to everything Jen said. I thought she laid out. In fact, that was kind of my talk to PBGH. My job was to try and rile them up a wee bit, to give them a wee bit of backbone. I would just add an added wrinkle. I think in addition to the list that Jen laid out of what they're interested in, I think they do see a major opportunity in what they're calling advanced primary care, which is a lot of the digital features. One of their concerns, and Elizabeth Mitchell and I may send a blog your way, Matthew, is that, and it's what I've been preaching, is that some of the digital solutions may end up being more expensive than the old model. And I'm really worried about that because I think there's a lot of flaky accounting going on. So I think you're going to see people like PBGH be more activist in curating solutions and refereeing some of these solutions. That was my suggestion to them. And also going after the middlemen more aggressively, holding health plans to account, holding PBMs in particular. And PBGH has announced, Emsana RX, where they've launched this Emsana subsidiary. So I would watch PBGH because they are the lead, it's Walmart, Disney, Boeing. It's the most advanced purchasers. And if they can get more friends and do what they're trying to do, I think it will send repercussions down the food chain. Because after all, they own all the margin. This is the thing I've been trying to preach to them. The entire health delivery system and the drug industry is predicated on getting that 300% of what it actually costs to deliver the service.
Yeah, worth noting, though, of course, that if you add up all the future expected revenues from all the decks that get sent to Sunny and Bill, the healthcare system is going to be about like $28 trillion.
No, but that's, if you wanted to make a forecast of health spending, that's it. It's the sum of the growth aspirations of the actors. Hey, it's Bob Evans 101. It's like supplier induced demand.
But no one gets funded for saying we're not going to cost any money.
That's true.
Well, no, but I mean, to be fair, right? The pitch is, and it's real, that if you could do what one organization can make a shed load of money by lowering costs overall, and that's kind of what Amazon and Walmart historically have done, right? And if you look at, I'm not sure Apple's lowered costs overall, but they certainly brought a lot of stuff to us that previously we couldn't have or was very expensive. And if you compare everyone's buying Netflix, or the Netflix subscription supposed to go out to the movie theater, for 5 people. That argument is true. It just hasn't come through in healthcare for a bunch of reasons that we've discussed as nauseam. I'm just worried that if you look at where we really need to both save money and improve health, which is, yes, employer-based care is one area, and we're stuck with that for historical reasons, but it's traditionally in the Medicare system and the Medicaid, and the Medicaid populations, the people who cost a lot of money. Where we seem to have put certainly in MA, but also to some extent Medicaid, certainly in MA, we've put the incentives very highly towards, can we play games around around upcoding, and we not really focus on, can we pretend everyone's sicker than they actually are? And we have the exact situation we've had, when you were telling me this with Bob Evans 20 years, nearly 30 years ago, Ian, which was that Medicare Advantage, or whatever it's called, Medicare Risk as it was back then, it's more expensive than the standard Medicare program. Just because of the games people are playing, and that remains the case. So, yeah, I remain worried.
But I'd love to hear from Bill and Sunny on this, because I think, if you net all this conversation out and you say, what is the opportunity? An enormous amount of capital has been thrown at these new actors, and I'm not a complete nihilist in this. I think we could actually make a big difference, particularly using the levers were described of employers. But I think we need scalable, and I think, Sonny, you made that point. We really need to have scale solutions here, not 1,000 points of light. So I guess the question I would have for you guys is, are we going to see a massive consolidation in the next 24 months of these plays into a few really powerful companies that can deliver? That to me is a really interesting game changer if it were to happen.
Yeah.
Because right now they're a couple of $1 billion revenue, the big guys. I mean, that's like a small health system in Nebraska, for God's sake.
Tiny. 24 months is, an aggressive timeline. But, I do think that in general, we do expect these types of companies to see consolidation. And we already are seeing this happen in the healthcare world, broadly speaking. The one challenge is that, healthcare in general is a fragmented industry. It's historically, up until relatively recently, not been an industry that has consolidated. That's changed a little bit with some of the health systems buying up other health systems, some of the PE guys buying up clinics. We'll see if the regulators allow that to continue. But outside of that, has been a very fragmented industry. The question is whether or not the technology companies will follow that trend. Many of the investors are betting on that to some degree being the case. I don't think it'll be a winner take all in many of these sectors. Take mental health, I don't think there'll be one or even a small number of companies that deliver all of mental health. But within certain niches, I do think it'll be a winner take most, or a winner take a significant chunk of the dynamic, just given how some of these things play out. So take telemedicine, for example. I do not think it'll be one player who serves 70% of the market, but do I think it'll be likely that there are 3 or 4 players that serve 70% of the market? I think that that's quite possible. And if you have a dynamic like that, it is very possible that you do get scale advantages and scale efficiencies. One thing I'm very mindful of is I do not want to have companies that are just adding cost and more inefficiency to the system. And historically, let's be realistic here, most technologies, whether it be new machines, new medical devices, even new therapeutics, even as they've added value, have always universally added cost to the healthcare system. And the hope is that technology, while they add value, can find a way to decrease costs through efficiencies. We don't know, honestly, if that will be the case, but there is significant hope that we can do this. There are some proof points that this is possible, but it's not yet been definitively proven out at scale. But this is the only hope, in my opinion, that we can generate, meaningful bending of the cost curve. If not, we're going to be stuck with a system where, a couple of years from now, we're dealing with $10 trillion of healthcare spend, and it's only going to get worse from there.
So, Sonny, I want to push you on one thing, and then I want to go to the transition phase in the market. But the one thing to push you on, and maybe bring Bill and the rest of the team here, the rest of the gang here, is the issue of DTC and new players coming in, finding things that weren't treated before. So mental health is the obvious one. It's a cerebral top of mind. It's grown incredibly fast.
Totally.
Now, I don't think it's fair. It's fair to say there is a problem with mental health for sure, but we weren't spending, and maybe that shows up elsewhere in healthcare costs. But we're also now encouraging people to treat stuff which they probably weren't treating before, and maybe they're not spending that much, but it's definitely ticking up now. And
absolutely,
a lot of what you're seeing is the DTC arms race, and there are companies doing, ketamine, magic mushroom,
everything,
everything, right? And most of this is like it's under the deductible for the high cost for the high deductible health plans, and can I get you in to see somebody, and can I get you the right meds or whatever? Now, good, bad, or indifferent for the quality of care. Who knows about that? But a lot of this to me is pushing more treatment. We haven't really seen any proof that it's reducing stuff on the other end yet, because that's a long way away. So is how much of what you're talking about is happening is people doing stuff in that arena? Because you're in a couple of these companies.
We
like
do.
Health and elsewhere.
Let me try and run through just a couple of quick thoughts on that. One, just high level, we're seeing a shift towards consumerization and verticalization of healthcare, and that's a trend that I think will absolutely continue. More and more folks are going to want to get their healthcare in a consumer-friendly manner. They're not going to want to have to go through the gatekeepers of old, where you have to go to your PCP, they have to send you to a specialist. You have to wait 3 months to finally see someone, then they get finally to, whatever prescription medication. Whereas you can now go onto your phone, click an app, and then hopefully appropriately get prescribed the therapy that you're looking for. That experience is much more desired by at least a sizable portion of the population. So you can see why those types of companies are growing very quickly. And there's also a verticalization component as well. Like, I know if, for example, I have migraines, that I want a migraine treatment. Like, that's what I'm looking for. I don't want to have to go through all this bureaucratic process through my traditional healthcare provider in order to get treated. I know what my problem is. I want to get that. So I think that will absolutely continue. In many cases, I think that that's perfectly appropriate. I have headaches. I need to get my headaches treated. Like, I'm going to go get treatment for that. In some cases, like, you can argue that maybe that's not super appropriate. And there's been pushback around some of these cases where the medications are maybe being used in a recreational manner, or and things that wouldn't, from a medical perspective, be totally indicated. And that makes me a little bit uncomfortable, to be honest. I think that's, for better or worse, just what happens when you get things like this grow very quickly. Hopefully that's something that can be regulated and addressed as this sector matures, but I think that comes with the territory. Fortunately, I think that's a relatively small portion of it. But if I look at it from a macro perspective, honestly, I don't think that that's going to drive overall healthcare costs in a way that's totally negative. So I'm not concerned about that driving costs in a negative way. I do think that this will continue. I do think that it will contribute somewhat to cost, but I don't think it's going to be a major cost driver in a way that I'm concerned about. All
right. Okay. So we have about a little over 10 minutes left. I've got to get onto the point of getting from here to there on this transition of digital health and whether there's consolidation or whatever it is. And I'm going to show you guys a screen. I don't often do this on the gang, but I thought, given who I have on the screen, this is my little portfolio. And I think I've got everybody who is in the world of digital health on this. There are some large market cap, if you ignore IQVIA and Cerner, who are sort of real traditional companies at the top. All this lot. So the one I wanted to bring your attention to is this column here, which is the 52-week range. And how many of these companies are sitting squarely at the bottom of their range, and how many of them found their range was much, the top is at least double, in some cases triple, and go up to, where's Teladoc, more than triple where they have been in recent weeks. So I assume, this goes, all those who must have been watching this, certainly, and I had Bill on a session at our conference that Jess and I ran a few months back, all know that this has been happening. We've had pretty much a bear market for the most of the year. We had this incredible bounce at the start of the year, last year and start of the year, bear market in digital health. It's actually not just been in digital health, it's been a lot of different SaaS, and online services. And really the reason the NASDAQ really mentioned at the start and the S&Ps kept going up was basically because of Apple, and it's 3 or 4 stocks that have been riding up. So I guess my question is, we're talking about consolidation, we're talking about these big players and doing more and more. Most of that, I think, was expecting that they would be using that high stock to buy a lot of other companies. And yet now we're seeing the private companies raising hundreds of millions of dollars, still, with valuations that are higher than many of their competitors who are now already public. So can I ask you, Bill and Sunny, to comment on how do you think we get from here to there? If I'm a public company and my value is lower than somebody who just raised $200 million or who's doing a quarter of my revenue, how do I do this consolidation without, I don't know, without putting the two of you out of business or having to work even harder than you're already working? I don't know. How do we get there?
The interesting thing about, so traditionally, I would say 4 or 5 years ago, most, if not all, digital health companies didn't go public. They were sold privately. And the beauty's in the eye of the beholder, right? So they regardless if it was a high valuation, if the strategic or whoever was buying it felt it had the value, they would buy it. The problem when you go public is now you have the public market looking at you. And what happens with a lot of the digital health companies, the valuation doesn't support the public IPO or the SPAC. Sometimes the industry or investors don't know how to they don't understand the P&L of some of these companies and how they operate and what are the fundamentals of a digital health company versus a brick and mortar company. Some can mimic it actually relatively easy, others can't. And so, I think part of why the chart you showed, why all those public digital companies or healthcare companies aren't performing well, is partly because of a lot of it's a lack of understanding. A lot of it is they shouldn't have gone public in the first place and can't support, their P&L can't support, the pricing of which they went public at. And so I think that's a problem. I was on one of your calls, I think that Jess was doing, and I thought the woman, I can't remember her name, said there was something like 17 billion in unused SPAC money, healthcare SPAC money. And the problem then becomes is, well, they have 2 years to spend it. People are raising money that may or may not need the money, and they're just going to take the money because it's there. They get some liquidation, but is that company really worth, or are they viable enough to go public? And the answer is probably no, but the money is there. And so, there's just I think there's just some fundamental problem. The question is, when do the analyst market catch up with some of these companies and maybe start to review them in a different way that's more traditional? But there's some problems going public, to be quite frank with you, in the health, and at least the digital health market.
So how do we get from here to there, right? If we have now 40 or 50 companies public, which weren't 2 years ago.
Well, I think that's where you'll see some consolidation. I think the problem is, I think we've spoken before, you look at Teladoc merging or buying Livongo. Well, Teladoc's going to have to keep expanding their therapeutic presence beyond where they're in today in order to get scale. They're not going to be the only player, as Sonny said, but in order to grow, they're going to have to do M&A. And where that's going to come is the consolidation. So what I see in a lot of the public side of it is some consolidation, because that's the only way these companies are going to survive and grow. But I still think there's a pretty healthy private market, for these companies. You don't necessarily have to do it, but the valuations, there's a bubble, I think, on valuations in our market, and especially in the public. But I think the consolidation piece is my general thought of where some of this is going to play out. That's how we get from here to there. I don't know what Sonny thinks, but
I'm in very strong agreement. I think the short answer is don't go public too early. Many of those companies that you had there are fantastic companies. Certainly not all of them, but a handful of them certainly probably went public a little bit too early. SPACs kind of created some weird incentives there for sure. But the fact that the valuations are correcting is not actually a long-term problem. That may create near-term opportunities. Consolidations, in my opinion, actually in some cases can become easier when these valuations correct. A target that looks not so attractive when valuations are high may look much more attractive when valuations are lower. It may not make the actual M&A process easier per se, because you have to convince the shareholders and all of that, which can be more challenging in a public environment. But assuming you can get over those hurdles, from an acquiring company's perspective, that target may look far more attractive at a more reasonable valuation. So I would actually suspect you'll see more acquisitions happen, assuming the environment supports it, in the next year or two, as these targets get to more reasonable valuations. You may, in some cases, even see private companies that, as you pointed out, have valuations that are exceeding their public peers, finding ways to acquire and take private some of their public company peers. So that may even happen in the next year.
Do you think there was enough? I mean, so there's a question between the strategic, right? So I mean, Bill, you mentioned a company. I think you guys sold it to Boston Scientific or something like that. I forget who it was recently, but there's that traditional exit route, right? Somebody, Optum buys somebody, or Aetna buys somebody, or whoever. A big, well-capitalized company is the acquirer. I'm much more concerned about the private companies who are growing fast but are getting these hefty valuations and raising these huge rounds. We mentioned Cerebral, but Hinge Health has raised over $1 billion. And you go down the list, right? There's a lot of companies in that space. Do you think that they're likely to be acquiring public companies and taking them private, or are they also, are we going to see a really significant shift in the private and in the valuations in the private market for digital health? And are you guys going to be seeing that some of the numbers that either you've been investing or that you've been looking at your colleagues investing we're going to see a series of down rounds to match what's happened in the public market? Where do you think that goes for the next little bit?
I think you'll see some down. I mean, look, and Sonny will test this. You have to be a disciplined investor no matter what, because if the valuation doesn't support, or the P&L doesn't support the valuation, you can sit there and hope you'll do a massive IPO, but the reality is maybe some of the investors will get out, but the public doesn't get out, right? They take the brunt of it. But I just think it's a bubble happening across digital health, but there are some areas of digital health, though it's not, there's some actually really good areas that we're starting to see. And part of it is we're starting to see real world data and real world evidence kind of be more mature and come into focus right now. So when you look at companies that are in the clinical development side using AI to do things like patient identification, patient stratification, where the data is actually validated and shows outcomes, those companies are seeing massive rises in their valuations that maybe doesn't necessarily match, but those companies are extremely valuable because pharma needs those companies. There's a willing customer. So I think you have to really look at the sectors of digital health. The patient care delivery is harder, I think, from a P&L and survival perspective. I think more of the data companies and more of the back end of care, or what I call the front end of care, where you're doing patient identification, patient stratification, or even the back end where you're looking at patient reported outcomes. These type of companies, I think, are doing really well. And will continue to do well. It just depends. You got to look more broadly at digital health than just the care delivery component of it, which is probably struggling a bit.
Yeah. Just very briefly, I think if you look at the companies some of the ones you mentioned, but in general, the ones that are having these incredible valuations, they're being valued off of phenomenal historical growth and expectations of very robust future growth. The ones that hit those targets, they're going to continue to do really well. I'm not concerned about any of those. The reality of it is not all of them are going to hit those growth targets. And the ones that miss, those are the ones that are going to have some challenges. The ones that do hit them, like I said, those are going to be in fantastic shape. The ones that don't, those are the ones that may, have some of those challenging financial rounds. But the ones that are going to continue to be on those trajectories, those are the ones that are going to be on a really, really fantastic upward trajectory.
So I assume that the defining qualification for that is that you two invested in them.
Of course.
All right. We're very close to the end of our time here. So I'm going to do the quick traditional how we get out, which is to go around and see what people are expecting, looking for, forecasting as we head out the end of the year. So I'm going to start with you, Kim.
So theoretically, between now and Christmas, Congress has to pass the debt ceiling legislation and Senate has to take up the Build Back Better bill. So it's going to be a question about whether we're going to see Santa Claus or the Grinch in the next couple of weeks.
I think the Grinch. Jen.
I think Bill started by just saying, can this year be over soon, please? I just hope we can all wrap up and look forward to a happier and easier 2022.
A couple of tough years. Bill, what are you looking for next, apart from getting the year over?
I want the year to end, so as much as Jen said, just have a good time. I think one thing we didn't mention that I think is really interesting too is I think the social determinants of health component and health equity is going to be a top priority coming up, and as it relates to all the topics we talked to today around access, around better care. Where does digital play within that? And that's kind of an interesting area that is on my radar right now.
Sunny.
I'm expecting this to be a defining year for digital health, and I'm hoping that we end the next two or 3 weeks with positive news on COVID and Omicron so that we can start next year on a positive footing.
Fingers crossed with that one. Ian.
Yeah, well, I share that whole fingers crossed, although I'm a bit concerned looking at the numbers. I just want to pick up on this last thing. I learned a lot from Bill's presentation at your Techies Policy Conference. The business fundamentals will win out. And the other point, just in regard to this other conversation, I'll watch your little portfolio closely. I'm not an investor. I'm just a interested observer. But I do think a lot of these people are sort of masquerading, we're a tech company when they're really a services company. And, physical touching of human patients is part of all of that. And the economics are very different than just selling SaaS software. And I just think that is part of the great starting out that's going to happen over the next 12 months. So I applaud you gentlemen who are putting your money where your mouth is, which is a good thing. But
no, it's not really there. It's not really their money.
Yeah, well,
let me tell you about I'll tell you about my Teladoc trading.
Don't get me wrong. We need the innovation. We desperately need the innovation. And I wish all these entrepreneurs well.
All right. Well, with that, we have come to the end of another perfectly good hour that you've spent in the company of the THCB gang. Here's who you've been seeing today. Kim Bellard from the dulcet Midwest of Cincinnati, where the snow will soon be on the ground and life will get harsh and miserable. Ian Morrison and Sunny Kumar, both from Menlo Park, California. Jen Benz from San Francisco, where everything is crazy. And as far as I can tell, either there is no crime or the whole city is in complete dystopian chaos, depending on who you believe. And Bill Taranto from all the way from New Jersey. They were your THCB gang today, December the 9th. We'll be back with another gang in a week's time. And I think that is that's not the Christmas episode where we have like 20 of us on. That's the one on the December the 6th. That's the December 16th. Same time, same place, 1 p.m. Pacific, 4 p.m. Eastern on the video, or if you are listening on the podcast, anytime you want to pick it up. This is Matthew Holt saying, thanks very much for watching. Really appreciate you watching and listening. Thanks to my guests for coming on and giving us a bit of a fun conversation and knowledge today. And I will see you next.